The current guidelines still go for and say, well, amiodarone is the medication. It seems to be, however, there was just a great study, very, very good study, that just came out early this year after the recommendations were produced, where they compared amiodarone versus lidocaine, which they've been doing back and forth for years, and this time they also said we're going to give a placebo and just give some water, okay? So the results with all those, there was zero difference in survival whether we just pushed water or actually pushed these fancy medications. The bottom line of this is the medications are useless in ventricular fibrillation from what we understand at the moment. If they're defibrillating, they need electricity right away, and that's the only chance they have. The rest of the stuff, so wasting time to put a line in, it's a nice thing, we're all programmed, we've got to get the line, we've got to get the medications, and that's, you know, it's not a bad thing, that's just sort of how we program. But in fibrillation, it's like, you know, it's fine to get that in, it's fine to get it going. You're not going to hurt the patient anymore, but we're not doing anything. And if this delays this, then we have hurt the patient. All right, so defibrillation, this is all about electricity, the rest is kind of moot at that stage. So that's what the focus is going to be on. That's what the focus of the doc should be on. And so knowing that, it kind of helps us as well. It's going to be like, well, I know more than anything, I've got to get this patient on those pads and fired up on the monitor, get that defibrillator ready to go, because that's what they're going to be asking for right away. All right, so we're pretty much like coming to the end here. So I kind of wanted to have some like take-home points of things, of just kind of organization, kind of how we're doing this. Okay, all right, so we want to plan ahead. If somebody's coming in, we know that the interventions are tough, all right, but if we get them early, they are helpful. If we get epinephrine early, it's helpful. If we can defibrillate them early, it's helpful. So the more organized we are when the patient arrives, the better the chance that we're going to be able to provide those life-saving interventions early. So organization actually turns out to be like the most important part of the whole ACLS algorithm, all right? Because we can do the right stuff, but if we do it, it takes us 10 minutes to do it, it's meaningless. All right, as opposed to we do the right things in 1 minute, it's got a good outcome. Okay, asystole, we still give epinephrine, we try and give it early as possible, but asystole still remains a poor prognosis. If your heart is not beating, you are dead, unfortunately. Okay, PEA is becoming more survivable. We're looking, it's got better prognosis. There's certain things we're specifically looking for. If it's a narrow complex, okay, and if it's faster, they've got better prognosis here. We're going to try and use the ultrasound quickly to rule out any mechanical obstruction causes. We're more likely going to be using calcium and bicarb in these patients if they've got some conduction abnormality. Ventricular fibrillation, early defibrillation. Everything else does not matter. All right? And then return of spontaneous circulation, okay, we're going to get them to the cath lab if there's any evidence of there being an MI, okay? And if not going to the cath lab, we're going to start cooling them, all right? And that's what we're going at. All right, so, questions?
Dr. Gerling, if you walked into a patient's room and you witnessed them going into a VFib,
Yep.
do you think you might still give them a thump in the chest?
Yes.
It'd be a reflex.
Yeah.
It would be for
Because it would be
too.
really cool if you got the patient.
Because you don't have anything ready,
Yes.
and that's
Yeah.
all you have is your fist.
If you got your fist, yes. So precordial thump is still, it's, you know, there's very few like actual measurements.
I
where
think
like,
that would be a
we're gonna do-
reflex of
But
what-
yes, but it'd be like if you suddenly go in, I'm going to try and do that. And it's like, well, we're kind of getting, because once in a blue moon it works, and it's pretty cool when it
That's
works.
right.
But again, is there like a hard evidence
As
based
you're calling
literature
for
to do
help.
this? You're
Boom.
calling for help at the same time, but you can give them a precordial thump. But they've got a good prognosis that they're going into ventricular fibrillation there, because even if you're kind of running around, you know, right away, they just need to be defibrillated. And it's
Right.
kind of like, okay, switch the defibrillator on, I got to put the pads on, and if we're sort of organized, it can go relatively quickly, and we don't need to kind of completely freak out. And doing the CPR like right over those 30 seconds is not going to make too much difference, and really I want to get the pads on right away. I don't really want to do, you know, the CPR is important, certainly if this is going to be delayed, but right, if it happens right in front of you, the instinct, the reflex, let's get this thing on, shock them. Yeah, yeah.
Or the paddles in gel.
Or the paddles and gel, absolutely. Whatever comes quickest, you got paddles, gel,
Yeah.
put them on, shock them. Yeah, yeah, good point. So, so those are kind of sort of the take-homes and the thrust of kind of what we're doing. So, if we go through an arrest situation again now, if we were to come and say, okay, we've got an arrest situation over here, all right, and maybe, actually, you want to go through a couple of rhythms? I don't know. Oh, our time's at 3 o'clock already. So it's kind of, so we can stop the recording right now. This is kind of the main thing of this. Let's go.